Welcome, and today we will talk about warm perfusion, beating heart transplantation, and our participation in the trials assessing this strategy of heart transplant. Relevant disclosures for this talk today is Dr. Shukrallah's accent is not really Southern, but my accent is, so. So just a few words about what the talk is going to be about. So we'll talk about organ shortage. That is a known fact in the heart transplantation world. Then we'll talk about ex vivo, so outside of the body, perfusion of the heart with DBD hearts, which means for hearts from patients where the death is determined by the lack of brainstem function, and ex vivo perfusion, so outside body perfusion with DCD hearts, so heart donated after circulatory determined death. So organ shortage is a known fact. Nobody needs to hear it again, but I'm going to quickly mention it. Despite all differences in allocation strategies worldwide and in the country, the number of heart transplants yearly has been pretty stagnant for the last 30 years. We all know that heart transplantation is considered still a gold standard therapy for end-stage heart failure, whether it's ischemic or non-ischemic. We know that it provides excellent survival. Every decade, the survival is slowly improving. It's most likely associated with improving interdisciplinary perioperative and postoperative care and improving immunosuppression strategies. Comparing to optimal medical strategy, which is overimposed here on this graph, it provides huge survival benefit, which is also a known fact. Patients that are sickest on awaiting heart transplantation always take priority, and this always is a goal of any allocation system to prevent any deaths on wait list. And despite differences and changes, and even recent change on heart allocation in United States, deaths on the list still happen, and up to 20% of patients never make it to a heart transplantation because the available, a suitable organ never becomes available for them. Distance is the main a main obstacle in terms of organ allocation and delivering organ to recipient site. And the reason for that is that heart is extremely sensitive to ischemic damage. Between the time of arresting the heart in the donor body to the time until the heart is reperfused in the recipient chest, we have about 4 hours. And in this time, the heart has to be preserved, has to be procured, delivered, sewn in, and reperfused. So as you can imagine, taking heart from West Coast to East Coast or the other way around, it is extremely challenging. We're talking here about traditional cold preservation, where the heart is stored on ice and delivered in the box, which many of us has seen, and after being implanted in the recipient chest is reanimated after reperfusion. The second obstacle is the quality of organ. So there is a lot of organs that are not necessarily perfect, not necessarily bad, but there is a lot of data from imaging studies or hemodynamic studies on the recipient sites where make us be very careful about accepting the organ for transplantation. The reason is that obviously every program is very highly scrutinized in terms of quality and results of transplantation. And also, we really don't have any way of evaluating and assessing those organs in the donor body. From the moment the brain death happens, we have 24, 48 hours before all the irreversible changes in the end organs happen, because a dead brain has negative effect on many organs, including heart. Let's imagine a place like Hawaii. There's about 60 to 70 hearts every year that go to waste and never get allocated because the distance between any closest heart transplantation center, there is none in Hawaii, precludes the safe delivery within 4 hours implantation and reanimation of the heart. And that's why ex vivo perfusion strategies potentially can help us with recovering those organs and delivering it on time to recipients. Expand trial is a trial we were part of that examine ex vivo perfusion strategy for hearts that normally would not meet criteria for standard donation. This was a US IDE trial. It was a single-arm study. The hearts that were a point of interest in this trial were hearts that normally would be turned down because of suboptimal quality or increased distance from the recipient side. And this is actually the most common reason why those ex vivo perfusion strategies are being developed. So the donor criteria were ischemic time over 4 hours, which was the most common, and then some kind of a suboptimal quality of the organ. So donor over 45 years of age, downtime, cardiac arrest time over 20 minutes, moderate hypertrophy or non-specific coronary artery disease. The trial had had two effectiveness endpoints. The primary was a composite of patient survival at day 30 and freedom from severe primary graft dysfunction within the first day. And the secondary effectiveness endpoint was donor heart utilization rate. So how many hearts that were perfused on OCS during the transportation were then accepted and implanted. And safety endpoint was the rate of moderate or severe primary graft dysfunction within the first month. The preservation of the organ in this trial was done on organ care system provided by the sponsor of the trial, Transmedics. So what is Transmedics? It is a portable ex vivo organ perfusion system intended to preserve a donor in a near normothermic and beating state from retrieval until the eventual transplantation. It consists of few components. As we can see, there is a detachable cart on wheels that can be very easily detached from the console. And the console has a pulsatile pump, kind of like an old pulsatile type LVAD. It has quadrox oxygenator that we all know from the ECMO and cardiopulmonary bypass world. Has infusion pumps for different type of infusettes that perfuse the organ during the transportation. It has some sensors that tell us about the oxygenation, blood flow, and this type of data during the transport, and detachable control panel that communicates with the computer, with the brain of the device via Bluetooth. The device has hard drive. Everything is recorded during the run, and USB card for data collection. And then there is a disposable insert that is open in a sterile fashion and connected to this console during each run after the organ is accepted by the recovering surgeon at the donor site. I would like to turn the stage now to Dr. Shukrallah, and he will tell us what it looks like in real life when the organ is recovered during the run.
All right. The most challenging part of this is this picture that you see. It's essentially the first time that we drain 1.5 liters of blood from the patient before anybody touches the patient. No cross clamp, no perfusions, nothing. So we collect about 1.5 liters. And that goes to the perfusion, who's already primed the system. The perfusionist primes this machine with proprietary solution, adenosine, epinephrine, calcium, and various other supplements that you need to perfuse the organ with. We collect the blood, and once the blood is collected, it's kind of go time. The perfusionist now circulates the blood through the system. And we kind of set up these are the additives that we're adding to it. Sorry. All right. I feel more official now. But anyhow, so once the system is primed, the procurement kind of moves along the standard procurement where we arrest the heart with a Del Nido solution, about a liter of Del Nido solution, which is less than the normal procurement, because we're going to reanimate this heart, as you'll see in a minute. And then we put cannulas in the aorta, and and then another cannula in the pulmonary artery. So 2 cannulas are secured to these 2 areas. The heart is then brought onto the machine and connected to it. I don't know if you can appreciate this, but the heart's upside down. We found that this is the best way to relieve the kinking in the pulmonary artery. Pulmonary artery is a very flaccid structure, so it needs support. So if we flip the heart over, we found that this is the best way to relieve the kinking that happens. Anyhow, and then the last thing that you see here is a vent that's placed in across the mitral valve. So this is kind of a live shot. This was a procurement we did. This is our 3rd procurement, which was done in New York. The heart is being attached to the machine, and I think I'm closing. So initially, the heart comes flaccid. It gets attached to the machine, de-aired, attached to the machine, and then immediately you biventricularly pace it. After you biventricularly pace it, you do what I'm doing now, which is closing the whole system, which is closing the IVC, which remained open. So that's that. And then you can see here the heart's pumping. It's attached to the aorta here. The pulmonary artery comes here and to the drainage cannula, and then you're venting the heart. Part of the disposable mechanism is this ability to cover the heart and have it kind of reside in its as near a chamber as the pericardium. It also offers us a sterile covering for the heart, because from then on out we kind of don't enter this space anymore. And then it's covered, and we begin to warm the organ, which is cold now. We begin the warming process, and then we begin infusing it with the solution. So what you'll see here, this is the collecting chamber. This is a compliance chamber, which allows you to have a pulsatile flow, oxygen delivery there, and then that's the return cannula, comes into the pulmonary artery, and that's the rate limiting step for us to measure coronary flow. And then we'll begin to leave the hospital. Our perfusionists are extremely vital for this. This is a definite two-person operation. And then we're on the plane. On the plane, really, there's the picture really, I call the plane ride the dark side of the moon, because we have no communication. So there's certain things that you have to do to this organ to maintain its viability, and those things are. There's a lot going on here, but all I want you to focus on are the top numbers. Your coronary flow. Coronary flow, we know, needs to be about 700 to 800, in that range. The other number that you can look at is this. This is called the AOP, aortic pressure. And these two things kind of, we augment these two things to preserve this organ. And our objective is to drive down lactate, but not driving down too quickly, because then you hyperperfuse the organ. If you drive it down too slow, the organ also becomes edema. It's this jostling effect that's going on. And initially, when we're doing this, we very reliant on the company to help us run these things, because sometimes you have to run things out of the parameter. For example, coronary blood flow per the textbook is you run it at 700, but sometimes we run it at 9, and at times, it can be as much as a liter, because we're trying to get the initiate this driving down of lactate, and if you do it too fast, then the organ becomes edematous. So anyway, that's to tell you the thing. We've kind of augmented what we do. We get a couple blood draws and kind of get the organ set for success, because I can't talk to anyone at the company after I take off. And the more you do it, the better you kind of get at it. So now we're back at the donor hospital, where we begin to cool the organ. You can see this is the organ is being cooled, because you can see the heart's slowing down, further slowing down, and then finally we kind of arrest it by cross-clamping and giving on the machine and giving plesia. The organ is then separated from the machine, and then we decannulate it from the cannulas that were placed, and do various cuts to relieve the aorta and the pulmonary artery to prepare it for transplantation. So I'll kind of go over one patient. I want to tell you, we're going to thank a lot of people at the end, but I can't tell you how valuable the company is to us, especially the procuring surgeon. They make themselves available to us to really take quite a complex few minutes, and they really make it take the anxiety away. So I'll show you the things that they do. So let's just take, for example, this donor, a 45-year-old female, and as you can see, the thing I'll draw your attention to, anticipated cross-clamp time would be greater than 4 hours, so this person would never accept this heart because of distance, and of course we were able to accept it. And again, the two parameters I tell you that we look at is your coronary blood flow and aortic blood pressure. So you can see here they're being maintained in these, so this is your coronary flow. You can see it's about 700 to 800 on this particular patient. And then your AOP, which is, we like it to be around 80. So how do we achieve this? Well, we achieve this by the solution, this maintenance solution that has adenosine in it. We have some epinephrine. We've got calcium. We've got buffering solutions. So we're augmenting this solution, this purple here, you can see we're increasing our flow to maintain these pressures in the aorta and coronary flow. So this is all furnished by the company at the end. So it really helps us understand what we did right and what we did wrong. If you can't read charts, they really spell it out for you. I'll show you in a minute. But again, here you can see that your lactate's driven down. So our target lactate has got to be below 5. And you can see we're well below 5, even in about the 2 range, and that's kind of that. And then if you, before I get to how they spell it out for us, so this is really the most fascinating slide for me. The first line looks at donor cross-clamp to placement on the OCS, about 29 minutes. It's usually about 30 minutes across the world at centers that do this. Your perfusion time, well, it can vary. In this particular case, it was 6 hours. The longest time has been about 9 hours and 25 minutes in Papworth, England. I think we have the second longest time, 8 hours and 4 minutes. But anyhow, these are the things that you spend on the organ. And then you bring it back and you cool it, and then the last line is when we separate to implant, which is an hour. So to make math simple, because I'm not good at it, 59 plus 29 is your cold ischemic time, which is, about an hour and change, about an hour and 30 minutes. This is just fantastic. You couldn't, if you did it, or if you did a normal transplant at this hospital, it would take longer. So the company, tells us what we did wrong, because if you didn't read the charts right, and in this particular case, I hyperperfused the organ a bit, and they told me you could have dropped your coronary blood flow. Why? Because we were able to drop our lactate to normal ranges, and we didn't need to make it look prettier, if you will. So yeah, there's a lot written here, but that's really the benefit of working with Transmedics, is they really help you understand this. And we are getting, I can tell by the organs that we're procuring and how we're doing it, we're less reliant on them because they furnish this feedback. Ooh.
You tethered. Thank you, Sammy. So we'll get back to the boring part now. So that's as Dr. Shukrallah mentioned, this is really the fascinating part. Meaning, we bring the organ over from the centers that are as remote as 4 to 6, 7 hours between the cross clamping at the donor site and reperfusing at the recipient site, and the heart ischemic time is hour plus. So getting back to Expand IDE trial, the number of utilized hearts was 75 out of 93, which means that the utilization rate was 81%, so very satisfying. And this is the breakdown of the total outside the body time with, as Sami mentioned, about half an hour between the cross clamp, cold flush, and recovery of the heart, then many hours in near normothermic perfusion state, and then about an hour between rearresting the heart on the OCS and preparing the heart for the implant and reperfusing in the recipient body. So across the whole trial, the total outside the body time was over 6 hours. So as you can imagine, none of these hearts would be transplantable in the traditional cold preservation strategy, and the true ischemic time is only hour and a half on in majority of those runs. In terms of the safety parameters of the trial, as we can see, the severe primary graft dysfunction was present in 1 in 10 recipients, and moderate to severe primary graft dysfunction at 14.7%, with excellent survival at 1 month of 94.7% across the trial. In conclusion, Expand met its primary effectiveness and safety endpoints, and resulted in very high utilization rate at 81% of all heart transplant of all heart procured, preserved, and transported on the OCS device. So that became a platform to suggest a good strategy for extended criteria donor hearts and further evaluation of this heart transplantation technique. Currently, we are at the Expand continued access protocol phase of the trial, and the objective obviously is to provide additional data and evaluate the hearts that normally would be turned down for donation because of the suboptimal quality or extended distance. The trial design is obviously the same as the IDE trial. We are one of the 12 centers participating. So far, it's been going very well. We did 4 runs in the CAP, and we are gonna reach 48 transplanted hearts in this part of the trial. Hopefully, within the next 3, maybe 4 months, we'll have FDA approve the device for commercial use for DBD donors after brain death hearts. The criteria for the donors in the Expand CAP are very similar to IDE. So the expected total cross-clamp time is kind of the key component. So it's usually a distance or some kind of suboptimal quality of the donor heart based on the imaging or hemodynamic data. Primary endpoint, again, is a composite of patient survival at 30 days and lack of severe primary graft dysfunction within 24 hours. I would say this is a very exciting time in a world of transplantation, and donation after circulatory determined death was present for other organs. Abdominal organs has been procured with this strategy for now a few years. About 2 to 3 years ago, DCD donors for lungs became available. Also, thanks to ex vivo perfusion devices. Specifically, OCS Transmedics was used for expand trial on lungs that we actually had the chance to participate with Dr. Shukrallah while at the University of Minnesota during our training. But I would want to talk a little bit about DCD hearts, which in my opinion is kind of the most sci-fi thing that we can imagine, because how can we utilize hearts where the donor death is determined by the actual heart death? So this is a really cool stuff. Talking about DCD hearts, we cannot skip the landmark trial by Dr. Masser from Papworth Hospital that Sami already mentioned. It's from United Kingdom. This was published in 2017, and this was a trial where hearts were retrieved from the donors whose death was determined based on circulatory criteria. And they utilized two strategies of reperfusion and reanimation of the organ. As you can see, there is a DPP, which is called direct procurement and perfusion, and that's the strategy that we actually are gonna use here in United States, and something that we cannot use because of the regulatory process, normothermic regional perfusion, which I will explain in a moment. But those two strategies were used to recover the hearts from the donor, and then the data was collected prospectively on 28 recipients, and then retrospectively the data was evaluated and compared to historic cohort from donors, DBD donors, so donors after the brain death, with standard procurement and preservation strategy, which is called ICE. And those two groups were obviously matched for donor and recipient's characteristics. When we look at the donor criteria for DCD hearts in that specific trial, those were so-called category 3 according to Maastricht donor definition, which is donor expected cardiac arrest or circulatory arrest within 4 hours of discontinuation of life-supporting or withdrawal of life-supporting therapies, i.e. extubation of the patient. So this is the patient that has still some brain and brainstem function. Patient gets extubated, and we expect that the death will happen within 4 hours. So this is category 3 DCD donors. Age of the donor was between 18 to 57. Obviously, this was all under consent. And the withdrawal of life-supporting therapies happened usually in ICU or anesthesia room. Structurally, the heart was obviously expected to be relatively normal, and ejection fraction over 50% before withdrawal of life-supporting therapies. So DPP versus NRP. So this is a direct procurement and perfusion. So this is the situation where the patient is either brought to anesthesia room, stays in ICU, or comes to the OR, is prepped and draped, and withdrawal of life-supporting therapy happens. So patient is extubated, and then everybody is ready and is waiting for the moment when the circulatory death happens. 5 minutes is given to every donor before the patient is pronounced dead, and then immediate chest and abdominal opening happens by different teams, and heart and abdominal organs are cannulated, so aorta is cannulated at different levels, is clamped at different levels according to a standard procurement techniques, and the organs are flushed, cooled, and preserved with cold perfusates. So this is what we do for both DBD and DCD donors, and this is the strategy that was utilized in this trial, one of them. And the other one, which we cannot unfortunately use here, is normothermic regional perfusion. So the same situation, withdrawal of life-supporting therapies happens. The patient is pronounced dead, and again, chest opening and abdominal opening takes place, and then the organs are cannulated inside the donor body and are reanimated and reperfused in donor body before they are accepted for transplantation. So that's as you can imagine, that gives us kind of an additional level of evaluation, assessment of the organ, specifically the heart. So in this case, we would open the chest, cannulate the aorta, cannulate the right atrium, put heart on the cardiopulmonary bypass, reanimate the heart, give it some time, then do TEE. We would evaluate the structure of the heart, ejection fraction, and with the Swan catheter and central venous pressure catheter, evaluate the hemodynamics. So as you can imagine, this is a different layer of safety and ability to evaluate the donor heart. When we look at the result of the trial, that's really quite fascinating. What the trial showed. So survival between the DCD and DBD donors matched for donor and recipient characteristics. There was no difference in 1 and 3 month survival. There was no also difference between the NRP and DPP strategy among the DCD procured hearts. But when we look at hemodynamics, when we compare DCD and DBD trial, donated donor, DCD and DBD hearts, there was significant difference in actually hemodynamic performance when you look on DCD versus DBD hearts, with the benefit of being in the DCD group, which I find very fascinating, because we're looking at hearts that were already arrested, because this is the definition of this donation, and they actually did perform better, which obviously this is just a theoretical assumption, potentially because of the reperfusion on the OCS on the system. In terms of the mechanical circulatory support need after the transplantation, there were no differences between the DCD, DBD, and no differences between the NRP and DPP strategies. The time on inotropic support actually was better on DCD hearts. However, the clinical significance between 4.8 versus 5 is probably not that high, even though the p-value was less than 0.05. Duration, ventilator dependent patients, there was a trend towards shortest time on the ventilator for NRP strategy within the DCD donors, and there was also a trend towards shorter hospital stay for DCD hearts when you look 20 versus 27 DBD. However, it didn't really reach statistical significance. But this is really the key slide here. 3-month and 1-year survival was the same. There was no difference between hearts that came from donors after circulatory determined death or brain determined death, and that's really what is the key message from this trial. I remember we listened to that talk at ISHLT, and that was one of the probably most exciting moments during those meetings. So we are literally days from being initiated for our US DCD trial. This is a prospective randomized trial. We are one of the centers participating. It is a concurrently controlled non-inferiority pivotal trial where we randomize people for potential for accepting the heart from DCD versus DBD hearts. And this is the construct of the trial. It's going to be a little easier to explain it here. So in order to achieve a proper number of DCD hearts, patients are going to be randomized after they consent to participate in the trial. They're going to be randomized with 3-to-1 ratio for possible DCD or standard of care hearts only. So if patients get to the group of standard of care heart only, which is a DBD donor and cold preservation, so very traditional transplant, those patients will not be eligible to receive a DCD heart, but the data will be collected, and then it will become a comparative cohort for for evaluation against DCD hearts. Patients that enter the arm of DCD heart possible may either receive DCD heart, depending on the match, or standard of care heart, because obviously if we randomize people to this group, we cannot say we're not going to give you a standard heart because obviously patients are waiting and this is a life-saving therapy. So that's kind of self-explanatory. But that's the design of the trial. There's already some transplantation, heart transplants were already done by Duke, MGH, Wisconsin, University of Wisconsin. So we're really, really itchy to get started and get some of this done. Definitely Sami is, I'm sure. So this is going to be a maximum of 15 participating sites and a minimum of 53 heart with DCD strategy is supposed to be transplanted, and at least 159 standard of care, so cold preservation DBD hearts in that trial. Then the data will be connected by UNOS and OPTN and analyzed. Donor criteria, as I mentioned, this is defined as death after withdrawal of life-supporting therapies, donor age between 80 and 49. And then how do we determine when patient's dead, right? Because that's really the whole thing. Some people say, well, when you don't have a pulse, when they stop breathing, but we extubate them, so they breathe different. So as you can imagine, it's not that easy. And then imagine we're going to a small hospital where we have somebody that never done a heart transplant or lung transplant or any transplant, and this is a anesthesia representative that's gonna determine whether this is whether the death happened already or not. So imagine the amount of stress here. Really, everybody's under to determine which moment is the right moment to pronounce the patient dead and turn the body into a donor. So this is why we have a definition of where we can pronounce the patient dead. So it's we want the patient we want the warm ischemic time to be less than 30 minutes, which means when the systolic pressure drops below 50 or peripheral saturation based on the regular reading less than 70%, to aortic cross-clamp and administration of the cardioplegia in the donor, because we do the DPP strategy. So open, perfuse, procure the heart. Has to fit within 30 minutes. So from the moment we say, okay, this patient just died, so pressure dropped below 50 or saturation was below 70, either or, to the moment where we have the perfuse that go through the heart, it all has to fit within 30 minutes. So opening, cannulating, and perfusion. Primary endpoint of the trial will be a survival at 6 months post-transplant, and this is going to be DCD hearts versus the standard of care from those two groups that I explained on the graph. And secondary endpoint will be a utilization rate of the DCD hearts. So in conclusion, organ shortage is still a limiting factor in the heart transplantation world. That's unfortunately on waitlist happen despite the changes in allocation strategies. Distance is a major obstacle because the heart is very sensitive to ischemia. Ex vivo perfusion hopefully will help us allocate all the organs and minimize the deaths on waiting list. I think DCD really is a future because will be able to recover much more organs with this strategy. And really cooperation between the organizations for procurement will be crucial to create a network that will be able to really utilize our organs. I really would like to give few thanks at this point because those are really the key people that made all of it possible. And I couldn't stress enough how important it is what LifeSource did, how patient they were with us, how supportive they were of the process. They really are the core people in the whole transplantation world. Transplant coordinators that screen patients for us, perfusionists that really mastered the device and took extra call to travel with us. And serve as perfusionists for OCS just like they do in the OR for cardiopulmonary bypass. Carrie Thomas and Carrie Williams that did literally 10 times more work than I ever will do in my life with papers. And the whole advanced heart failure team, because they really embrace the idea, which is a key, that we have people that believe in this. And I really, everybody says that every trial needs a champion, and really Dr. Shukrallah is a champion of this trial. He knows ins and outs of it. He did all the procurements. I couldn't thank him enough, and really I'm very grateful that we have him here. A lot of experience from his previous institution, a lot of experience from the training time. So I really would like to thank him for that. And I just want to finish and with the explanation why we're really doing it, because our real, true goal of all of it is that we get up at 6, have a coffee, read a newspaper, at 7:30, scheduled heart transplant is on the way. Thank you so much. I will be happy to take questions if there are any.
More of a comment than a question. I just want to highlight for those of you that weren't as familiar with this, you may not have appreciated or noticed that we're really the only non-university based center participating in this trial. And I think there's really three key reasons for that. One is the support and the championship, so to speak, of the physicians. The second is we couldn't do it without the foundation. And the third is that we've had tremendous administrative support. Tom Talley and Beth Cairns, a lot of this started when Tom was here, really stuck his neck out, and the capital outlay for this up front was not trivial. So this is really a collaboration of a lot of parts to the system. But I just want to thank both the foundation, the research coordinators, and the administration, because without that partnership, we're a relatively small transplant center. I mean, other places doing this, Duke, for example, is doing probably 50, 60 transplants a year. This is part of how we were able to be participating in this trial.
Thanks, Karol and Sammy. That was really instructive. What have we learned from being able to reanimate a heart from 30 minutes of warm ischemic time? It's interesting to me that can occur. Mm-hmm. And is there any of this information that could be utilized in other scenarios, say reperfusion of coronary myocardial infarction? I mean, is there something about this solution that is being used that is,
I think, thanks for the question. I would say, Scott, honestly, that whatever you asked, the answers, I think yes. Because honestly, sky's the limit here, in my opinion. The really limiting factors here is the regulatory process. We cannot just go wild and pick whatever organ we want and implant, because there's always a patient's life on the line. But when we really think about it, the organs that we often accept for transplantation with the traditional preservation, cold preservation, and traditional procurement strategies, those are actually organs that already went through cardiac arrest, downtime of 20 minutes, 30 minutes, 45 minutes. I mean, Peter knows better than me how often we accept organs because the recipient is really on a very short timeline, and waiting on ECMO or on dual inotrope, no option for mechanical circulatory support, durable. So it's not like we've never really done it before. Plus, first transplants that happen in the world, where Dr. Bernard did his first one, those were DCD donors. There were no brain-determined donors. Nobody knew how to evaluate people's brainstem at that time. So the death was determined by the circulatory death, and then the heart was recovered, and then it turned into a brain-dead donors. So we went through this before. We just never really put it into a organized structure like now. Do I think that there's anything magical about the reperfusion? No, I don't think so. I think there is something magical is that it's reperfused. I don't think there is a special medication substance or anything in the perfusate that makes the hearts recover. I think this is the timing and the fact that the heart is decompressed and it's reperfused. And that's really what as we all know, I mean, this is why we believe in decompression of the LV with myocardial infarction. This is why all the Impella trials are happening. I mean, we want the heart to be, the coronaries to be reperfused in a diastole as much as possible. So that's my opinion. Is it gonna be utilized? I hope so. I would really, I wish we could do strategies like normothermic perfusion in the recipient, in the donor body, because that really buys you additional layer of safety in accepting the organ and reperfuses the organ to normal physiological state immediately after opening the cavity of the donor.
What they are doing at certain centers is after the whole thing with these organs is reperfusion injury. And what they're doing at certain centers is introducing whatever research solution that they're working on to limit that reperfusion injury. So they'll reanimate organs. They're doing this specifically in lungs because that's kind of, I know the people that are working on that, where they introduce various scavengers to limit the reperfusion injury on the organ. This is what's really exciting, and this is what's going to take this to even greater levels to deliver more tailored care. Like, imagine if you can get a perfect cross match, an absolute perfect cross match, but you live in Washington and the organ is here in Minnesota.
Or Florida.
Or you live in England and the organ is in Houston. I mean, this is how you're going to get hearts that, if you saw Karol's chart on heart transplants, we tell everyone they're going to last 20, 25 years, but the actual number is that 50% of them are not around at 13 years. So how do you get 100% down to 20? You got to more perfectly, in my view, match the organ and preserve.
I mean, imagine no chronic rejection. That would be the hearts that last forever. I mean, we have those patients, but we have no idea who's gonna be like that because we just don't. And really, the distance is always the most limiting factor. It always has been. So yeah, imagine getting a perfect transplant, like from monozygotic twin. You know, it's the same. We would be able to do the same thing. But you know, that's you know, hopefully in the future. But just thinking about it, when those strategies become commercially available, I mean, we should really be able to expand our transplant population. This could be, you know, this could be huge. Yes.
Karol, thanks a lot, Sammy. That was great. So before you had heart in the box, were there any interventions you could do to extend the life of the graft? Like, I mean, have they ever done like ischemic preconditioning on the graft before you'd explant the heart to?
When the abdominal team severs inadvertently the aorta, then it's a ischemic preconditioning. To answer your questions, I'm not sure. I think that it's more of trying to optimize the hemodynamics towards as physiologic as possible before harvest. I mean, brain death has very detrimental effect on the body, and this is why the donor body has the supplementation of vasopressin, of levothyroxine, because those are the neurohormonal changes that immediately happen after brainstem death. So I don't know, but I believe that it wouldn't be in clinical practice or hasn't happened in clinical practice much, because it's more of a how do we keep them as optimal as possible. Maybe, Peter, you are.
Well, the only other thing I'm aware of is that's been looked at a little bit in other organs is something called persiflation, where rather than perfusing with a solution, you basically perfuse with gas. You basically send air down, you know, through the organ. And there's been some work on that. It has not reached a level of clinical use and is far behind, but it's at least another strategy that people have looked at using. As you can imagine, that's challenging to be sending gas through all these arteries and taking all this on a plane and so forth. But it's been a challenge. You know, that 4-hour barrier is a big deal. Hearts are realistically usable to 5 hours, and they really start to deteriorate after that. And they'll survive the transplant, but then they get restrictive physiology. It's like they get fibrosis, and then these are patients that then tend to be, they're not in heart failure anymore, but now they're in kind of mild heart failure. So you helped them, but not as much as you could have.
And as you can imagine, the coordination of the process with the 4-hour window on patients that have LVADs, had few sternotomies before, so-called dig out of the organ and getting everything ready and not running into problems, all of it. It's another layers of dangers, you know, and having this type of device that allows you to kind of have not have those time restrictions, not be in a rush, not to be between, you know, hurry up and wait, or suddenly you realize you have 30 minutes to take everything out because the heart is on the way and you don't want it to be ischemic. This is, I think, also big benefit of this type of device. So we're obviously very, very excited about that.
To my knowledge, the only thing that we've been able to do to extend the time is all mechanical stuff. Dig out the heart quicker. We also sew the heart by just completing 2 anastomosis and release the clamp. The organ becomes perfused. It's more difficult to sew because you're kind of sewing under blood. But if you looked at, you probably don't remember this, but on our ischemic time, after separation from OCS, the national average is 62 minutes. Ours is 59. We're making up that 20 minutes because we're releasing the clamp about 20, 30 minutes before, because we just sew the aorta and atrium and release the clamp. And the organ is being perfused as you sew the remaining 3 anastomosis, the IVC, SVC, and pulmonary artery.
This is what Sammy is talking about, 59 minutes here between, you know, flushing the organ on the OCS and releasing the clamp in the recipient body. So obviously aorta is a crucial component of the reanastomosis after left atrium. It's a bloody mess.
It's bloody, but
Literally.
you control it with a lot of suction. I mean, you have to be able to see this.
Everything is collected by
non-compromised.
cardiopulmonary suction catheters,
It is
but,
much-
but it's moving because it's beating, because we also already reperfused, and it's kind of like trying to sew a slippery fish that is trying to escape. So. No more questions. Thank you very much, guys. And